Welcome. My name's Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar. Today, we will learn about eosinophilic granulomatosis with polyangiitis, also known as EGPA, from Dr. Juanita Mora. Dr. Mora is an allergist and immunologist at Chicago Allergy Center. She has a special interest in education and preventative care of diseases. Welcome.
Thank you so much for everyone being here. It is such a pleasure and honor. I thank APFED for inviting me to be here today, and we're going to make it very interactive and fun because EGPA is a rare enough disease that we all need to be on the same page and try to help each other and partner up with other organizations as well, like American Lung Association and the Vasculitis Foundation. So EGPA is eosinophilic granulomatosis with polyangiitis, and today's talk is about tips for self-management. I know it's a mouthful, but we're going to break it down so everyone gets to know exactly what it is. First of all, it's a very ultra-rare lung disease that affects about 5,000 people in the United States. It can affect the lungs, the sinuses, the heart, the intestinal tract, kidneys, nerves, and other organs too. Formerly was called Church-Strauss syndrome. EGPA is one of the rarest forms of vasculitis, which basically means just inflammation of the blood vessels. And we see this increased level in eosinophils, which is a cell line within our body. This is why it's called EGPA. And adults with allergic asthma are going to be higher risk for EGPA and may have any combination of the following symptoms. For example, they can feel or tire while experiencing fever, loss of appetite, and weight loss. So when I think allergic asthma patients, one thing I always screen for, because in allergic asthma, I think of that patient who wheezes every spring or every fall. And I know climate change is making allergic longer, but when they come not only with that asthma symptoms, but they come with sinus symptoms as well too, then I have to screen for EGPA in these cases. Symptoms can range from mild to life-threatening, which is why it's important that we're talking today. And it depends on which organs are involved and the extent of disease. And symptoms definitely vary among individuals. Almost all patients have asthma and or sinus or nasal polyposis as well too. So they have a lot of congestion, they have trouble breathing through their nose, and then wheezing that accompanies as well too, and a higher than normal level of a white blood cell called eosinophil. So other symptoms that I have seen in patients include shortness of breath, chest pain when the heart especially gets involved, the lungs get involved, rashes on the skin, the vasculitic lesions that don't blend, so we touch them onto the skin, and normally a hive will blend, other rashes will blend, a vasculitic rash will not blend. Muscle or joint pain, lots of inflammation, right? Nasal discharge, sinus pain in the face, abdominal pain that can be accompanied as well with bloody stools, and numbness or actually loss of strength as well too, because nerves can also get involved within this inflammation of the blood vessels that occur. So rare disease. And EGPA is so rare, it isn't top of mind for a lot of patients. This is why I love talking about it and educating not only patients, but also my peers and everyone I can think of, because not everything is, we have to screen for zero. So it's a severe lung disease that can lead to permanent damage. And this is why it's important that we're talking about it today. So some of the facts that you should know about EGPA, we have about 11 to 14 million cases worldwide. Average age is 35 to 50 years of age, but can occur at any age. I have seen some children involved with EGPA. Fully split in males and females, very rare in children, and ethnic prevalence is really unknown. I also have seen ethnic prevalence in many cultures across and race and ethnicities. So I cannot say it's only one race or another. It actually affects anyone. It can affect anyone. So this is the hard part about EGPA. There are tests, though, that you can run to help us make the diagnosis. There's no single one test to make the diagnosis, but your doctor may order several procedures such as blood tests, scan to look at the chest, to look at the abdomen. And a tissue sample, especially if there's a rash, they might actually do a punch biopsy to try to diagnose exactly what the rash is and if it's truly EGPA. So often in my patients, like for everything else, one, you want to get a urine analysis because you want to see if there's any kidney involvement, if there's any blood in the abdomen, or any excessive protein, which may indicate inflammation of your kidney. Blood test. Blood test I always reach for is the EGPA test. The EGPA test is basically a test that we use to determine whether a vasculitis is truly present. When positive, it can be helpful in confirming the diagnosis. However, it's only positive in 30 to 50% of individuals with EGPA. And it can be positive with other diseases, but it's a good screening test. I also look for other inflammatory markers like an elevated erythrocyte sedimentation rate, which is called ESR, and a C-reactive protein that's also another marker of inflammation, because all of these tests may support the diagnosis of EGPA. We also, like I said, do a tissue biopsy, especially where there's a rash, determine, or if we think there's kidney involvement, if there is blood in the actual urine that's detected through the urine analysis or loss of protein, then a tissue biopsy of the kidney might actually give us the actual diagnosis. Imaging studies can also be helpful. X-rays and scans may reveal changes in the lungs, and signs characteristic of EGPA, such as full of nasal polyps, that can also be seen. A heart echocardiogram is also part of the screening to see that heart is not involved. And this is basically an ultrasound of the heart, and all patients with EGPA should be screened for heart involvement at the time of the diagnosis. So, treatment. This is where it gets tricky. So there's no cure for EGPA, but there's now treatment to help control your symptoms. And now in 2024, we actually have a lot of cool stuff in research, and we have more treatments available than we've ever had. So this is an exciting part of the talk today. But with EGPA treatment, one thing I always teach physicians, I always teach patients, it's going to be important to treat the underlying asthma. Like I said, 95% of patients with EGPA have asthma. So if we treat the underlying asthma, of course, it's going to help to control the symptoms, the inflammation of the blood vessels, inflammation of the bronchioles, etc. And with early diagnosis and proper treatment, many patients with EGPA can lead full, productive lives, and that's our goal. And the majority of EGPA patients respond well to treatment. So non-severe EGPA is traditionally treated with just steroids such as prednisone. But as an allergist and immunologist, I can tell you that we don't want people on prednisone for long periods of time, because prednisone can cause, over time, thinning of the bones. It can increase blood sugar levels, so put people at risk for diabetes. And it can also basically cause glaucoma, increase cataracts, etc., and bone thinning. So this is why we use it in acute phase to try to get EGPA under good control. But we also try to put people on immunosuppressants, so that way we can decrease that eosinophilic cell line and stop that attack that our immune system is having, because our immune system is so revved up, creating all these eosinophils and causing these eosinophils to deposit in different parts of the body, different organs, that we're going to try to suppress it. But what I was saying, one of the most beautiful things that happened last year is when mepolizumab or Nucala, which is a biologic that we use for asthma, got an indication for EGPA. Mechanism of action is a monthly biologic injection, and the mechanism of action basically works by the eosinophil line. So it's an anti-eosinophil actual drug. So when these eosinophil levels drop, people do well. They suddenly don't have the deposit of all this cell line within the different organs. And asthma gets under good control, because that's what it has the FDA indication. We know that severe EGPA, though, might need stronger medications than even this. So severe disease is really treated with, I tell them, these high strong drugs, such as cyclophosphamide, which is another immunosuppressant, and it's a cytotoxic agent, or rituximab, which is another monoclonal antibody antibody that basically is a biologic agent that helps suppress the immune system. And it's used for other actual diseases, but it does have an indication for severe EGPA. So the treatment is going to be based on manifestations and severity of disease. So EGPA team, I always say it takes a village, right? And for EGPA, we need a team. Effective treatment of EGPA requires coordinated efforts and ongoing care of a team of medical providers and specialists. In addition to a primary care provider, you may need to see the following specialists. One is a rheumatologist for your joints, muscles, and immune system to make sure they're optimally controlled. An allergist like myself or pulmonologist so that the lungs actually do well as well too. The asthma's under good control, and we avoid that permanent damage that EGPA can cause in the lungs. A cardiologist, if there's any heart involvement, to make sure that we take care of the heart. A nephrologist, because kidneys can definitely be involved to make sure there's no blood in the urine, no protein being excreted in the urine as well too. A dermatologist to help take care of any vasculitic rash that can occur. And a neurologist, because this eosinophil line can also deposit within the brain. And when eosinophils deposit within the brain, it can put people at higher risk for stroke. It can also put people at higher risk for dementia and early Alzheimer's disease as well too. So this is why it takes a village, and we want to make sure that all these organs are well taken care of. We suppress the eosinophil line. But guess what? There's also other things that you can do to help your EGPA. And these are top-notch actual recommendations I always give my patients. One is, if there's one vitamin that we could give everyone that would make their joints better, their heart better, it would make their lives a lot better, exercise. So exercise will help in EGPA. Remember, it fortifies your lungs, it fortifies your joints, it fortifies your muscles. So getting regular exercise is going to be very important. 2, eating and sleeping well. Remember, during our sleep, it's going to be when we generate, when these cell lines get to reproduce and kind of blunt, where our immune system gets to rest. So that's going to be so important. Eating healthy. So I always love 3 things I always recommend in a diet for patients. One is probiotics. Because since childhood, we get a lot of antibiotics for that ear infection, for that throat infection. Probiotics are going to be so key in making that gut happy and preventing that abdominal involvement that happens with EGPA. Fish oil. In any vasculitic actual inflammation, fish oil is your friend. Fish oil, 1,000 milligrams is what I usually recommend to adult patients, and at high dose, because it really helps get all that inflammation within the joints, within the heart, within the brain, within the skin line, cell lines, everything down. Third thing I always do also is the multivitamin. A multivitamin is going to be important because we need all the nutrients. Sometimes we don't get it all in our diet. And then the fourth is a Mediterranean diet. When we look at more of the vasculitic inflammation that happens, a Mediterranean diet with olive oil, with the good proteins, with the good veggies is going to be so important at maintaining homeostasis and decreasing all that inflammation. And then the other thing is staying up to date on your vaccines, like the flu shot, your COVID-19 vaccine, your RSV vaccine. For those people, it's just got an indication for 50 years and above. Because if we keep everyone healthy, then their lungs are also going to be healthy. Avoiding tobacco and other irritants that might compromise your lung health. Here, I also have to mention the flavored cigarettes need to be eliminated. No vaping either, because of the fact that there's a lot of chemicals and carcinogens within them. We don't know the long-term effect. American Lung Association is doing a 25-year follow-up studies on the effects of vaping and the effects of flavored cigarettes as well too, that we are now having an epidemic with. But what I have learned is from seeing a patient, a young 22-year-old who had been vaping, who lost a lung and needed a lung. So these they're not step-down mechanisms. If someone was smoking, that they should vape now because it contains less nicotine. Don't let the market fool you. It actually contains two of the mentholated e-cigarettes that were just approved have more nicotine than the regular cigarettes, just so you guys know. So we've got to keep our lungs nice and healthy. And then obviously staying up to date, like I said, with the vaccination. So living with the chronic lung disease can definitely be challenging. So we know that there's 3 wonderful organizations that work very, very hard to raise awareness on rare diseases like EGPA. One is the American Lung Association, where we have available resources on diagnostic tests, treatment options, access to support groups, etc. And you can learn more at lung.org. Second is the Vasculitis Foundation. The Vasculitis Foundation, I've worked with them in the past as well too. They have a lot of wonderful resources, a lot of fundraisers. They do a lot of awareness as well too. And then third, this wonderful organization to put together this actual webinar today, APFED. So you can go to apfed.org to learn more about any of these eosinophilic diseases. It's important to partner up with these organizations, work together to create more awareness, and also to try to get patients under wonderful good control, because now we have more resources, we have more treatments for EGPA, and we can make people have a better quality of life, and that's what it's all about. And I want to thank you, APFED, for the invitation to shed some light and knowledge on EGPA. And please hit me with questions.
Thank you for such a wonderful presentation. We really appreciate all the information and tips on EGPA. So as she shared, now's your chance to go ahead and enter some questions in the Q&A box so that we can have a great discussion. If you'd like, you can stop sharing your screen while we have our discussion here. So the first question here is about managing flares. And so this individual is on a biologic, but still has some flares. And so she's curious about options that she could try other than prednisone when on a flare.
Beautiful question. So some of the recommendations I have, one is if your flare is lung, making sure that your medications for asthma are optimal. If your flare is joint, that we make sure that the joints are optimized as well too, whether rheumatology gets involved, etc. There's usually an organ that tends to flare. For most people with EGPA, it tends to be asthma. So then it prompts me to, one, get them on a better inhaler that they can take every day to prevent those flares. Because when it comes to inhalers that they take and inhale, it takes 2 puffs inhaled twice a day for 5 years to equal 1 oral burst of prednisone or steroids. So it's a lot less and increased quality of life. And then institute some of the good things like exercise to decrease flares, the vitamins, the anti-inflammatories, the fish oil, the Mediterranean diet, things to increase your quality of life to decrease flares.
There we go. So we had somebody ask about the fish oil that you recommended. So someone's allergic. Is there an alternative to fish oil if someone can't take it?
Good question for an allergist. So yes, I often get this question for fish oil. So for example, there are formulations. So if people are allergic to fish oil, then they can do basically other anti-inflammatory things. So things that I recommend, macadamia oil. Macadamia oil is very, very anti-inflammatory, and it's one that you can find at your Trader Joe's, at Whole Foods, Amazon, etc. But it really works nicely. So you can substitute it with a tablespoon of macadamia oil.
Very interesting. Alrighty. So when someone has to use steroids for a flare, how long is that course generally?
So usually we do, depending on how severe the actual inflammation or the flare is. What I try to do is just use 10 days, and I usually wean it. So that way they don't go right into another flare. And I make sure that whatever the organ that was involved, that we optimize it just to make sure, or whatever the trigger was. Sometimes it's a cold, right? They get a really bad cold and that flares everything up. Or their little grandson comes in with RSV and then gets them infected, and this is what flares it. So making sure sure that, when we get them through it, my doses that I usually use is prednisone 30 milligrams for 5 days and 20 milligrams for 5 days, then off. So I don't go too high as far as actually using prednisone. I always tell patients it's a dose I would give a 3-year-old and a 2-year-old, but enough to get it under good control. And then I try to do more things with, especially the lungs. So now there's first well that we can use as rescue. So before we used to just use albuterol for any wheezing. Now, per the DINA guidelines and the new APFED guidelines, we have air now that has both an anti-inflammatory, so inhaled corticosteroid, and it has albuterol in it. So we get it to treat it, and people can do up to 12 puffs a day, and it really gets everything under good control. So something to learn more about.
It's great to know there's different options. Some people are still having a little bit trouble hearing you.
Oh, sure.
So if you could just lean in it a little bit again.
Of course.
Fantastic. Alrighty. So you shared some information about biologics, and people are curious, if I start a biologic, how long does it take to work to know if it's working or not?
So Nucala, when it comes to the data from EGPA, so that's the mepolizumab that basically anti-IL-5 or eosinophilic drug, anti-eosinophilic drug, takes 3 months, 12 weeks for you to see good effect, which is pretty fast. And it's a monthly injection, so I have seen it work really fast. And so that's one good thing. With the other biologics as well too, usually it takes about 4 to 6 weeks for you to see it, but Nucala takes about 12 weeks.
Okay. So someone who's joining us today has had a gastric sleeve in the past, and they're not allowed to take any steroids or anti-inflammatories. Is there another safe way to control a flare without steroids?
Yeah, so then the immunosuppressants will help as well too at that point. That's one thing that they can use, and especially because they can't use any oral steroids, or if it's lung involvement, they can do inhale. The inhaled steroids are still okay with the gastric.
Okay, interesting. So as you talked about, you had your slide up about self-management. You talked about exercise and probiotics and different things that people can do for themselves outside of some of these prescription medicines. So when you think of someone that's having challenges with their lungs and they're being recommended to do exercise, what type of exercise do you recommend?
So one good lung exercise, and I tell people, one is for joints, walk. Walking, just a nice soft walk, in yoga, right? Because yoga helps to relax anything that decreases inflammation. So for lungs, I like swimming. Because swimming actually helps with the development of lungs and the breathing techniques as well too. That really helps as well too. The other thing is people like weights, so going gentle on them. But weight training is very good because strength training actually will increase muscle mass. And muscle mass, whenever we have an increase in muscle mass, decreases the inflammatory drive. And the more muscle people get, then they're less likely they're going to be into asthma exacerbations or anything else, which is really great.
Okay, so probiotics come in a variety of different counts, and you recommended that as something to look into. While we're not looking for you to recommend one brand over another, is there a count or anything specific people should look for? Like look for XYZ on the label.
Okay, one easy way of getting your probiotics in, Greek yogurt. Greek yogurts are, I tell patients if they can get one Greek yogurt in the morning for breakfast, you're done with your probiotic. So any of the Greek yogurts is easy. If you want to do, don't get too fancy on the probiotics, honestly, because they can get the best with the multivitamin now with probiotics included. In babies, honestly, I even recommend probiotics in babies because that's what helps to fix the gut as well too. So keep it simple. That's my recommendation.
Great. Let's see. So if you have EGPA, how often should you see your doctor if you're not having symptoms?
Oh, if you're not having symptoms, everything's under good control. I usually do every 6 months, twice a year if their asthma's under good control. But they always have to follow up in the fall. Because in the fall, they get their flu shots. We make sure they have their COVID, if they're eligible for RSV. And we make sure as well, too, that their lungs are doing well. So high peak. So right now, we're in the summer, we're having an actual COVID wave that's starting now. 39 states are COVID cases, and during COVID, we wanted to make sure to take care of these patients.
So circling back to kind of the beginning of your presentation, would you mind re-reviewing what vasculitis is?
Of course. So vasculitis is basically an inflammation of the blood vessels that occurs within EGPA. It's secondary to the eosinophilic cell line. It's a white blood cell. So think about this white blood cell goes kind of crazy in your body, your immune system, and then starts depositing in different organs. So it deposits in the heart, causes inflammation within the heart blood vessels. Deposits within the lungs, causes inflammation within the lungs, the wheezing, bronchoconstriction. Within the skin, they get the rash that's non-glandular. Within the brain, so they deposit and higher risk of stroke, higher actual risk of dementia as well too. And in the actual kidneys as well too, this is why we do a urine analysis, because when this cell line deposits into the kidney, then people can have protein and blood in their actual urine as well too. So this is why we want to make sure every organ is in for it in someone who gets a diagnosis of EGPA. And then we make sure that those organs that are involved are well taken care of, and we suppress the immune system response to these eosinophils. So that's the whole goal.
Thank you for circling back to that. So people are also curious, if you have EGPA, are you more likely to develop other kinds of eosinophilic disorders like eosinophilic asthma, or even vice versa? If you have eosinophilic asthma, are you more likely to develop EGPA?
So if you have just allergic asthma, so that asthma that tends to exacerbate spring in the fall, then you're going to be higher risk for EGPA, just because your lungs are already sensitized, you're there. But in allergic patients, we often see a little elevation of eosinophils already. But it's when the eosinophil levels go really high, then that's when we call it other involvement as well too. Because if I think of my allergic patients, a lot of them have sinus involvement. A lot of them have lung involvement as well too. They come in here, kids and adults, chronic sinusitis, and then they have lung involvement as well too. And then the thing that kind of prompts patients to think of differently is they come in with a rash, and I'm like, wait, you've always had asthma, you've always had sinus stuff. You tell me you can't breathe through your nose all the time. They have nasal polyps, and then they develop that rash. But not vice versa. So if you have EGPA, you are not higher risk for other uses.
Okay. What about kind of familial or hereditary risk? If someone has EGPA, is there a greater chance that their child could have it?
The short answer to that is yes. And the reason for it is because allergic diseases tend to run in families. Just like I see tons of kids, I see the parents, I see the grandparents here in clinic, because they all have seasonal allergies. So it's all that cell line that kind of drives through. So they have higher risk, but not necessarily they're going to have it.
Okay. What are some other conditions that often occur while people have EGPA, often known as like a comorbidity? What are some things for people to look out for?
Sure, of course. So as we get organ involvement, I think that's what we hear the most, right? So this is when, if they have kidney involvement, then they can have acute renal failure or end up requiring dialysis, especially if the protein sedimentation has been a lot onto the kidney. Heart attack with the inflammation on the heart, then it can put them at risk for heart attack as well too. So this is why the good diet, the exercise, everything to keep the heart healthy is going to be important for the kidneys, and all the fluids are going to be really good. Good water, making sure the vitamins are good, and keeping all the anti-inflammation going. Because when I think of EGPA, I always think there is tons of inflammation going on in that body. And I always tell patients, we need to rev you down, kind of push a reset button and kind of bring you down. So things that are going to help them is, one is meditation. I always tell them, calming down stress levels is going to be so important. That's why sleep comes into play. The other thing I recommend a lot, acupuncture, because it really brings down the stress levels and allows people to just sit in a dark room with needles in them, but just relax. And it helps those organs as well too. And I mean, I have seen it work in lots of patients with autoimmune diseases weaknesses as well as vasculitides as well too. And it's a great alternative as well too for people who don't want to take so much prednisone. So that's going to be important. And then yoga, meditation, things to help relax, because we're trying to rub this body down. Yeah, I always think of the body as an overdrive. It's going, going, going. So we need to do things to just relax.
Okay. So you mentioned kidney health, and a question popped in about that. So someone who's listening is on IVIG for polymyositis. I'm sorry, I'm not sure how to pronounce that one.
Polymyositis. Yeah.
Thank
so
you.
That's skin. Yeah.
Okay. So they're curious how dangerous this is for kidney health, as EGPA can cause kidney issues.
So what was the exact question?
The person is on that medication and they're
An
curious
IVIG, right?
how dangerous it is for kidney health.
Okay, IVIG tends to be pretty much. So IVIG is basically we produce immunoglobulin. So IVIG is given for those patients in other autoimmune diseases. So that way it can give them, for example, the ability to fight back. This is what how I teach patients. So for example, in people who have recurrent sinus infections, recurrent pneumonias, sometimes their numbers are low, so not all their soldiers are working, so then IVIG needs to be given, and that's the concept. Now for this patient, polymyositis, so it's an inflammation basically of the muscles that occurs, and it's an autoimmune disease. So they're given IVIG to kind of counteract, so that way the body stops attacking itself. And one of the things is IVIG, because it's given through the IV, sometimes it can be given subcu. It can actually cause sometimes problems in the kidneys, but it's very, very rare. And obviously benefits in these conditions outweigh the risk.
Okay. So you've mentioned a rash a few times. Could you talk to us about what that rash looks like? One person's writing in asking, does it look similar to a mylar rash at all? Or like, how could you describe that rash?
Sure. So the rash is going to be red and sometimes circular. Mostly they're called target lesions that can occur. And when we touch these lesions onto our skin, normally a rash will blanch. So by blanching, I mean touch the rash and it's white, your skin blanches. But with these type of rashes, it does not. And sometimes it looks like, for example, a lot of people will describe it as burns. And it can occur in any part of the body. I have seen it in legs, a vasculitic rash. I have seen it in face. I have seen it in arms. It can occur in any part of the body. Back, chest, involved in.
And forgive me, I'm not familiar with the mylar rash. Is it at all similar to that? Was the follow-up
So
question
a
I had.
mylar rash comes with lupus. So mylar rash is going to be a butterfly rash on the actual teeth. So it's a little bit different. It also doesn't blanch, but it's butterfly actual teeth. So it's different.
So it's different. Thank you.
You're welcome.
I always enjoy learning new things from each one of these webinars we do.
Oh yeah, it's fun.
Absolutely. Alrighty. So as you've shared, people with EGPA work with a number of different specialists. And one challenge can be getting doctors to communicate with each other. Do you have any tips when you're not in a multidisciplinary setting in how you can encourage optimal communication between specialists?
Of course, if you're concerned that maybe there's loss in translation, right? Which can happen when you have multiple cooks in one pot, is tell them to pick it. Tell them, hey, Dr. Mora's my allergist. She suggested this. But what do you think? Do you mind giving her a call and discuss? Just because sometimes we have to go old school. Like I know people are, well, they can read the chart, they can read this, but I always tell them, you know what? Do it the old-fashioned way. Just pick up the phone and say, let's chat for 2 seconds. That's it. All it takes about Mr. Smith and what we can do to optimize everything.
Phone calls are a good thing.
Yeah.
Can you talk a little bit about nerve damage in EGPA? People are curious why there is so much nerve damage.
It comes with the inflammation. So with the inflammation of the muscles around it and the blood vessels as well too, then we'll get nerve involvement. So then, obviously they get the ulnar involvement, sometimes as well too, the radial involvement in the arm. And then they obviously start getting the tightening and the carpal tunnel syndrome as well too, that occur. Sciatica is a big one. It's a big, big nerve that runs down our butts, down our legs, and it can also get inflamed. And then people have trouble kind of going from sitting to standing position, or they have trouble doing things. This is why it's important to actual muscle stretch. This is why it's good to mobility. Because and strength training, so these muscles are strong, and these nerves actually get stronger as well too. And the whole fascia around our legs, around our arms, get that extra boost that they need.
Right. So at some point, people are on treatment for a while and they might be considering stopping it. So people are curious, when you decide to stop a treatment to look at something else, is it only related to symptom relief, or are there other reasons to consider switching treatments?
Well, switching treatments might be related when we should consider, and maybe talking to other doctors ourselves too, having a little bit of humble pie, which I totally do, is say a patient is not responding to treatment, right? So a patient who's not responding to treatment continues to flare up, continues to be hospitalized, continues to have symptoms. This is the patient where we need to kind of reevaluate and say, you know what? There's this new treatment. Maybe she might benefit, or he might benefit from this biologic. Or these organs just continue to flare. Why are we seeing asthma continuing in this patient? So then we got to go to the asthma specialist and say, okay, what can we do better here? Or the kidney specialist, this patient continues to have, I'm seeing on the blood test, increased protein. And maybe the kidney doctor is too busy because they're seeing a million patients, and then I catch it as the allergist, and then I can say, what can we do to kind of help these kidneys out a little bit more? So you have to work as a multidisciplinary team. And I always tell patients, be advocates for yourself as well too. If something doesn't feel right, follow your gut. If that asthma is not under control, if you're still having that chest pain, if your joints just don't feel right, then let's reevaluate. Say, okay, this is not working. Let's go to plan B. Then there's going to be a plan C. But there's always
there's lots of different options for things. So another concern or question that's coming in is about complications. What's the most common complication of EGPA that you hear about?
pneumonia. Pneumonia is the
Say
number
that
one
again?
cause. Pneumonia.
Pneumonia. Okay.
It's the number one cause of hospitalization because they have so much inflammation going into the lungs that when a virus or a bacteria, they're more likely to develop that lower pneumonia. And that is the most common cause of number one cause of hospitalization. Yeah. And I've seen so many cases of it. Sometimes it prompts the diagnosis of EGPA because the patient continues to come in with pneumonia, and suddenly they develop this rash, and they're like, wait a second, and people start connecting the dots.
Goodness. Should people with EGPA consider getting a vaccine for pneumonia?
Yes, a pneumovac. If they don't have it, even if they're younger than 50, get a pneumovac. So flu shot, pneumovac, COVID vaccine, RSV is now indicated for 50 and above.
Okay. Goodness. Is there, when a patient with EGPA has pneumonia, is there anything in terms of treatment that needs to be different because of the underlying EGPA?
Once we have lung involvement, because there is a lot of inflammation within the lungs, and if they have pneumonia, then doses of steroids are going to be higher in those cases. So they might require actually IV steroids initially to bring down that inflammation and that drive, so we don't start getting the cell line completely going out of control. And it's called eosinophilic asthma, eosinophilic pneumonia that basically occurs, lobar pneumonia.
Yes. Well, thank you so much for all of this wonderful information. We really appreciate it. And people are commenting in about how much they've learned today. So they're echoing my sentiments. Before we wrap up today, is there anything we haven't discussed about EGPA that you'd like to share?
Well, I want to, first of all, thank you for inviting me to be a speaker today. And thank you to everyone who joined the webinar. It was my pleasure. One thing I would like people to take away from EGPA is people would feel very defeated before and say, well, now my heart's going to get involved, my kidneys, I'm going to get pneumonia, I'm just going to do all these things. And their quality of life really, really would go. But I want to say that now in 2024, we have a lot more treatments. We have a lot more ways of people under good control. And we've learned a lot more about it. It's an ultra rare disease, but that just means we have to read more. And not every patient reads the textbook. So we have to think outside the box. And if any physicians are on the line, I want to tell you, let's think outside the line, and each patient is different. And we should tailor treatments based on that patient. And for patients, you keep your hope up because now there's so much treatment and you can make this difference.
Wonderful. Well, thank you so much for sharing all the information and resources to help people be able to manage EGPA. Thank you also to our education partners for their support of this webinar series, including Bristol Myers Squibb, GSK, Sanofi, and Regeneron. To continue learning more about EGPA, we encourage you to explore resources from the American Lung Association, from APFED, as well as from the Vasculitis Foundation. In fact, APFED will soon have a new toolkit for EGPA patients available. It's developed in tandem with the Vasculitis Foundation, and we look forward to sharing it at our virtual conference in a few weeks. So speaking of which, our annual conference, EOS Connection, is coming up. We are headed to the DC area this year from July 11th through 13th. You can register at apfed.org/conference. And if you can't join us in DC, there is a virtual option as well. So you can get all the great information from wherever you may be at that time and beyond. You can also continue learning more about eosinophil-associated diseases by subscribing and listening to APFED's podcast, Real Talk Eosinophilic Diseases. In the latest episode, we talked with Dr. Nirmala Gonsalves about food-induced immediate response and eosinophilic esophagitis. You can find the episode at apfed.org/podcast, as well as on Apple Podcast, Spotify, Audible, and more. Finally, we encourage you to continue the discussion started today in our online network on the Inspire Network. It's a great place to connect with patients and caregivers for support. You can check it out at apfed.org/connections. Thank you again, Dr. Mora, for joining us, and for all of you for tuning in for APFED's EOS Support Webinar Series. If you have a question that did not get answered today, please email us, mail@apfed.org. I hope everyone has a great afternoon.
Thank you so much, Jennifer.
Absolutely. Thank you for joining us. Have a great day.
You too. Bye.